We finished part 1 of the PRI episode with Alexi making the argument that since local kinematics, aka the way a joint itself moves, was a poor predictor of injury, then it is very unlikely that distant biomechanics, like that of the jaw, is something we need to worry about for pain in other distal joints in the body. Enjoy as we pick up from there, and we'll finish the Conor video and then get into some thoughts around PRI in a clinical setting. Nothing you hear on this podcast should be considered medical advice.
No, I was going to bring up just the ergonomics of low back pain and how I think like the ergonomic chairs are the equivalent of almost like an occlusal splint. And even like in ergonomic studies, we see that the ergonomics of a chair actually doesn't make any difference for the onset of low back pain. So let me share my screen real quick. I just pulled the study up. It's a really quick study.
Let me remove my share.
So it's a study that has to do with looking at 2 randomized control trials, and real simply, they just don't show this guy right here. If we just go to the bottom, conclusion, unless supplementary high-quality studies provide different evidence, chair interventions are not recommended to reduce low back pain or discomfort and activate trunk muscles. So pretty clear indicator that when we use what's basically the equivalent or analogous to like a malocclusal splint, which is like a lumbar brace or a lumbar brace that's on a chair that's supposedly supposed to increase your ergonomics and increase your static posture, it actually has no effect. So similar thing, similar idea.
I agree. Yeah. Okay, let's finish this video. Oh, hang on. Let me share the screen for Conor. So I'll give credit to Conor. He cited contradictory evidence, and try to provide an explanation. I honestly respect that.
Now you can build it up on one side more than the other, so that way you can create more even contact of your teeth. But again, it depends on how it's being made. When people create these splints, a lot of the times they're not taking into account the position of the cranium and also the cervical spine and the rest of the body posture. Now, to be transparent, in a lot of these studies, they did not describe the position the body was in when they took the impressions to make these splint devices. And that might be a big hint right there. In order for us to be able to properly create some sort of appliance that improves the position of the jaw and the bite, we have to take everything into account, and I think a lot of people aren't doing that. Alice Lamb is a dentist, and she is part of an organization called Applied Integration Academy, who are the first people that are truly taking into account the entire body when they make things like splints. Alice has explained to me that when she makes appliances for the bite or the mandible or the cranium, she really makes sure that she puts the person in a neutral position, meaning that they have their heels grounded on the floor. They have a neutral position of their lumbar, thoracic, and cervical spines. And also their cranium is in a position that will allow them to express neutrality as well. And then she takes the impressions there. If we can all agree that it's pretty likely our posture is being influenced by our jaw and our bite, then doesn't it make sense that the rest of our body and that posture is influencing what's going on up here as well? It's a two-way street. I see all the time when we create more neutrality within the bigger structures below the head and the neck, a lot of the times occlusion changes. People's bite noticeably changes and the position of their head changes. So wouldn't it make sense if we're trying to determine what kind of an appliance and how to make that appliance for a person who needs that, they should be able to access a more neutral position of their body first, or just simply put them in a position to then get everything in alignment so that way that they can make that appliance that will help hold them in that alignment. This might sound crazy, but as this industry progresses, I strongly believe that the best trainers and the best coaches are going to have relationships with orthodontists, with dentists, with physical therapists, and all these other disciplines that can come together and help understand how can we get someone in a position that restores movement and more neutrality to the body. So that way the body can access all these different positions it couldn't before, because the body is being held in a pattern. It's being held in something that is limiting oftentimes its ability to either shift over to one side or simply shift into either side. And if this is being significantly influenced by the position of a jaw or malocclusion, then we need to be able to refer out effectively and have a dialogue with how we as movement specialists can get the body in a good position position, but work alongside dentists who can create proper appliances to allow for repositioning of the things above the level of the neck. If you want more information, I'm going to link the studies down below in the description. And again, stay tuned for more content that's coming out very soon of how we can align these things better and pick exercises for those who it is appropriate for that will help take into account things from head to toe, from the head to the rib cage and thorax, all the way down to the pelvis and the feet, and effectively integrate these so we have a better ability to sense the ground as we shift from side to side, because that's the name of the game. Can we effectively control our center of mass? Can we get everything aligned to help control our center of mass more effectively? And for some people, they need specific dental appliances that will allow them to do that. I will link more resources for that as well.
Okay, perfect. Let's just go over the other interesting papers. So there's Herzog 2022. Hang on. Yeah, we'll cover it now because I don't want to cover this ever again. I've read enough about this for my entire life, I think. So, improvement of cervical spine mobility and stand stability by wearing custom-made mandibular splint in male recreational athletes. So that's a study that Conor cited again by Joanna Herzog in 2022. Yeah, so I'll just put them on the screen so you guys can read it. Basically, it was a non-randomized, non-controlled trial with no specification of how they even recruited the participants. So this could be a case series where the scientists chose which subject to report themselves. And it was only of 80 healthy male athletes whose swaying during balance, tax, and range of motion were measured before and after a splint that was supposed to center the TMJ in a centric position, despite there specifically being no occlusion problems in these patients. So I'm not sure what they're correcting. It's like you're already normal, and then we're making you more normal, I guess. The effect size were extremely small, so they used percentages to make it seem bigger, but in reality, we're talking about no change in terms of flexion or extension and 2-3 degrees of change in lateral flexion. So let me show that. So yeah, they're using percentage change. But if you look at your actual values, I think we can see them on the screen. It's literally like it's 2 to 3 degrees of change in lateral flexion and rotation on either side from wearing the splint. Even the authors say that the effect size is so small that this should not be considered an effect size, but actually just a trend. Their weight distribution swayed 8.2% less when standing with 2 legs and then on 1 leg. The differences were, again, very small, and the confidence intervals had significant overlap, meaning this could all be measurement error. So look at these differences. Like, there's so much overlap. Like, honestly, you have to squint to see a difference. Yeah, I would not consider that meaningfully different. All right, and then let's go for the other one. So there's Baldini 2018, Correlations Between the Visual Apparatus and Dental Occlusion, a literature review by Alberto Baldini from 2018. So you guys can read it on the screen. Oh, hang on. Yep, okay. So this is a review of mostly case controls and cross-sectional papers of medium quality, and it doesn't even talk about the claim at hand, but rather the correlation between dental occlusion and visual disorders. It does not concern the claim that treating the jaw will improve range of motion or hip range of motion or posture. So I think this is an example of, like, you know, if an individual has like funky genetic disease or something, sometimes there's this central trend that causes everything. And again, I can go back to Ehlers-Danlos. One of the phenotypes that can explain it is that the allele, I'm not good in genetics, but like one of the genes that codes your collagen is different. So your collagen is more disorganized, or I'll use like very simple, I'll do a Huberman and like explain it wrong, but in a way that people can understand. But it's your collagen is more extensible. It's not as like elastic as others, or not as stiff, basically. So people have like more range of motion. Their joints, it's easier to dislocate, and that can, for example, it can go like Marfan is a similar phenomenon, but like Marfanoid syndromes, which are really common in like really tall players with really long arms. Like when you're above 6'5", you get screened as a kid. When you have that, you get like hypermobility as well because your collagen is different, if I recall. But also you can get heart disease. That's one of the reasons whenever I find someone that seems to have hypermobility, I refer them to the GP to make sure they don't have that presentation, because it can lead to early heart attacks. So there's an example. So if we took the logic of Conor here, we could be like, hey, having like extensible finger, that biomechanic leads to heart attacks. Whereas all you're looking at is a central cause of multiple problems or anomalies. And again, I think people who tend to be asymmetrical in one place tend to be asymmetrical everywhere, probably because, again, maybe that's just how they are. They have the asymmetry joint or something. I'm not sure. Or maybe they're just hypermobile and that leads to asymmetries. Again, we don't know. But I think it's more probable than saying like, oh, this little asymmetry leads to that other one, blah, 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 and that's like super important. Again, we can't dismiss it outright. I'm just saying my bias here. So that was the Baldini 2018 paper, and then I'm just going to close this and do this one instead. So Sagaguchi, that's a crazy name. I mean, I find it crazy because I'm white and stupid. Examination of the relationship between mandibular position and body posture by Kiwamu Sagaguchi from 2007, I think. Yeah, so it was a single-blind randomized crossover trial of 45 adults looking at the impact of adjusting posture on mandible position versus adjusting mandible position on body posture. The only difference between groups was the order of the tests were conducted in. They used wax mouth pieces, including one that was placebo, i.e. it did not interfere with occlusion. One that brought the canines edge to edge, and one that corrected the occlusion, so aligned side to side with a 20% overbite, which is considered like the best one. Yeah, that's a heavy one. So when subject used a 9mm heel lift under the right foot, occlusal forces shifted to the right side and backwards compared to no heel lift when in standing. This was not tested on the left side, so we don't know if that would have happened as well. The effects were not consistent. Sometimes the placebo mold induced more sway on some measures, but only the canine to canine position changed the sway on other measures. So overall, these results were arguably contradictory to each other, all the while being mostly displaying no difference if we look at most figures. Overall, the effect size, except for the heel lift's effect on occlusion, at about a 45% difference, were very small, and this study was too small to be called anything other than a pilot study, as there were 10 statistical tests conducted, each with 3 to 5 groups being compared. So that's an insane amount of comparisons being made for such a small sample. Overall, none of the effects of changing occlusion mattered for actual postural measures / body weight distribution, since the placebo group, in the placebo group, the only measures that were different were either displayed equally in the placebo group or the placebo group performed the same as the correction group. In other words, all we can say from this paper is that having a heel lift under the right foot might increase biting contact pressure between the molars on the right side more in standing, based on a dramatically underpowered study. And this was not compared to placebo in SOL. So this might also just be placebo. The difference in occlusal forces could also just be explained by the fact that when you lean more on one side, your head tends to move to compensate, which affects occlusion through gravity alone. All right. Overall, the study is unusual beyond acting as a pilot study to maybe expand into an actual well-powered study in the future. All right, we're almost done, and thank God I don't have to read that shit again. Again, all respect to the scientists. I'm just saying this is not why I became a physio. Okay. So, effects of experimental leg length discrepancies on body posture and dental occlusion by Nozomi Maeda, my bad. It was 2011 paper, I believe. I'll put the abstract there so you guys can read it. So, single-blind randomized controlled crossover trial of 30 young adults were given insoles of 1 to 10 millimeter under both feet to mimic a leg discrepancy, while the center of pressure, the COP, during 3 standing postures, so standing with no heel lift, standing with left heel lift, standing with a right heel lift, were measured, as well as occlusal forces during these postures. So it turns out that having a heel lift on the left side leads to putting more weight through that left foot and having a little bit more pressure between the left molars and than the right molars. So you squeeze more on the side that's lifted. The differences in occlusal forces could also just be explained by the fact that if you lean more on one side, your head tends to move to compensate, which affects occlusion through gravity alone. And that's from the paper itself. Moreover, changes in head position may have occurred that affect the lateral occlusive force distribution. Where the head position laterally shifted to the heel lift side, the mandibular resting position may have shifted to the same side in response to gravity. So I wasn't even looking for that. I came up with that idea, and then the the authors were like, yeah, you're correct. Like, I'm not crazy for assuming this. Also, this study is very small considering they conducted 20 statistical tests with 10 different groups, 10 installs with only 30 subjects. This is a ridiculously underpowered paper. The effect size were also atrociously small, being absent in most cases. And when present, not even exceeding 5 to 10%. Let me pull that up. Again, this is a great way. I feel like, yeah, if you remember anything from this paper, I think it's a good explanation of how to conduct a paper on shit that you want to be true. You take a very small sample. It's cheap to do. And you take an incredible amount of measures, and then you only report the stuff that matters, and you don't talk about the effect size. Because something will come up. If you flip a coin enough times, you'll get 3 in a row. And then you can just say, oh yeah, when I did it, holding something in my mouth, that did it. And you don't have to report the effect size at all. So if you look at these, there's so much overlap. Differences were less than 5 to 10% in terms of difference. That's so small. In fact, only some of the higher insoles value were significant, but only in 6 out of 20 statistical tests. So overall, this it doesn't matter. So this seems like a clear case of the red Skittles give cancer method that I talked about earlier. AKA, we report the positive results only after taking away way too many tests, thereby only showing false positives. Overall, all we can say from this paper is that people tend to put a very tiny bit more force in the foot and teeth on the side that has a heel lift, based on a sample way too small, jacked with extensive statistical tests with no placebo comparison groups, like a shot insole that could have been used. All in all, this study is unusual, beyond acting as a pilot study to maybe expand into actual well-powered study in the future. So I think you're seeing a recurring theme. And again, we talked about that 63% figure earlier, where they took these all shitty studies that were biased, and they can't even get 13% above chance in terms of showing an effect. They don't talk about the direction of an effect, which is often contradictory or doesn't seem to matter based on their premise. But we need a meta-analysis, I guess. And okay, I'll finish. There's another one. So Nota and all from 2017. Let me share that one. Yeah, share. And after that, we'll actually get into meaningful clinical impact of these. Like what you should do with that data. All that rambling that we did, you don't need to do that. You just need to listen to that part after. So Nota and all from 2017. Postural stability in subjects with temporalmandibular disorders and healthy control. Comparative assessment. Sandro Nota. Can read the abstract. So my analysis, it was a comparative study of 25 people with temporalmandibular disorders, comparing 19 healthy subjects to 25 people that had, again, those temporalmandibular disorders. People who have TMJ pain seem to sway more standing, as per 5 out of 12 measures being statistically significant only. Indeed, people with temporalmandibular disorders swayed 1 millimeter per second more in standing with their eyes open. This doesn't include, and also, again, that's the main relevant thing, and this doesn't exclude the hypothesis that these people were just more stressed. So they sway more and grind their teeth more, which can cause temporalmandibular disorders. Like grinding your teeth and stress are linked according to a host of data. It does not mean that the temporalmandibular disorder is causal of more swaying, or that those differences in swaying and standing are bad. Also, the 6 statistical comparisons are way too many for 44 subjects. This is getting ridiculous because it's a recurring theme. Again, overall, this study is too small to be relevant, too many statistical tests, and there's no way to make a causal inference here. So summary of the cited papers, it's small sheet papers. And also there's a very, very recurrent theme of Baldini being a co-author. I don't know who that guy is or what he does. I think he's a dentist or a physio, but the point is he really wants this to be true. I think it's his baby. And that kind of affects, he's like the Stuart McGill of TMJ disorders, I guess. And in the sense that they affect posture. But also, I guess the argument that comes up after that is that there's also no clear correlation as what's good or bad posture in literature. We cannot say causally, oh, this is good posture, this is bad. So the 2 big studies on this, first one is C.T. Swain 2020. So it's a very famous paper. Let me share this. And I've cited this paper before. It's like one of the first papers I cited when I started doing this scientific thing. So there's no consensus on causality of spine, postures, or physical exposure and low back pain. A systematic review of systematic reviews by Christopher T.V. Swain from 2020. So basically, scientists cannot find a causal link or an agreement as to what is good or bad posture. So two independent reviewers screened 4,285 publications with 41 reviews included in the final review. Both positive and null associations between spine posture, prolonged standing, sitting, bending, and twisting, awkward postures, whole body vibration, and components of heavy physical work were reported. Results from meta-analyses were more consistently in favor of an association, whereas systematic reviews that included only prospective studies were less able to provide consistent conclusions. So again, that's like back to my point where I think that a lot of what we're observing is we're making a mistake of finding the chicken before the egg or something like that. It's, again, when you look at people before they have pain, their posture does not seem to be causing pain. It's just that people, when they're in pain, they're moving differently. So I always use this analogy. If you look at how people move after an ankle sprain, you're going to say, oh, you're limping. You had an ankle sprain because you're limping. Whereas if you look at people before they sprained an ankle, they were not limping. It's just they're doing that as a compensatory mechanism. It makes it more comfortable. It's a way to offload the zone. So when you have low back pain, maybe slouching is helpful. Maybe leaning when your neck hurts all the time, maybe slouching a little bit more is more comfortable temporarily. And that's why we observe this, because it's a lot of people with neck pain. What you'll see, the most painful movement is extension, like going back. So obviously your neck's going to be more forward. It doesn't mean that was the cause of the pain, like not being back enough, right? And that's normal. Like you put more pressure on your spine when you go back. Where was I? Okay. Evidence that these factors precede first-time low back pain or have a dose-response relationship with low back pain outcomes was mixed. Despite the availability of many reviews, there is no consensus regarding causality of physical exposure to low back pain. Association has been documented, but does not provide a causal link for low back pain. And we're going to go back and we're going to go further. And we're going to talk about that. That was for low back pain. We're going to check for neck pain. Let's look at neck pain. Try this tab instead. So this is the relationship between forward head posture and neck pain, a systematic review and meta-analysis by Nazreen Fawzi Mahmood. I'm probably pronouncing that wrong. I apologize, Mr. Mahmood, from 2019. So what they found, basically, it's a meta-analysis showing no correlation between forward head posture and neck pain for adults, teenagers, basically. Fuck that word. While there was a 4.84 odds ratio shown for adults and with neck pain. So what does that mean? What that means is that adults with neck pain are 4.84 times more likely to have forward head posture. So people watching this, it's when your neck is forward. So basically the position that people are going to tell you, hey, sit straight, you're sitting wrong. That position. It was linked with neck pain. But again, it was not based on prospective papers. So they looked at people that already had pain and they were like, hey, your neck is more forward. Yeah. Have you ever asked someone to do a retraction when they have neck pain? Often they can't because it hurts too much. So obviously you're going to be standing more protruted. Yeah. The problem is that the data in adults is only based on retrospective data of 3 studies totaling only 203 participants, with 2 studies showing an effect versus 1 showing no effect. The heterogeneity was also immense. Okay, so the overlap, the odds ratio went from 0.14, so basically no effect, to 9.44. So it was borderline crossing 0. If it crosses 0, so it was 14%, like 0.14% more. Was it 0.14? Yeah, if it was 14%, a little bit more to the left, it would be considered not a real effect, basically. Even the paper, yeah, they mentioned the high heterogeneity. We can see it on the screen here. And yeah, 1 out of 3 studies. Hang on, I'm going to stop sharing this. 1 out of 3 studies, so the Netaji et al. 2015 paper, showed no statistically significant correlation, while the other 2 did, with most of the effect coming from the only study, so Low et al. 2010, of low quality, while the other 2 papers were of moderate quality. This meta-analysis also does not include 2 more recent prospective papers, which completely go against this, which we will now mention in this section. So the most famous one is the Karen V. Richards paper. I'll just put it there. So these are, again, higher quality paper because they look at people before they had pain. And this one's quite famous. They took pictures of 17-year-old girls, not like that, get your mind out of the gutter. And they looked at who got neck pain. They basically grouped them into like slouching a lot, slouching not too much. Is that it? Yeah, and they found the group that slouched more. And again, they followed them for 4 years. The group that was slouching more or had more forward head posture seemed to have a trend towards having less neck pain. So it wasn't statistically significant. So after taking into account, what is it? PNP? Persistent neck. After taking into account persistent neck pain at 17 years, sitting neck posture at 17 was not a risk factor for persistent neck pain at 22 years of age in males. Whereas in females, more relaxed postures, so slumped thorax, forward head, and intermediate postures were protective of neck pain compared with upright posture. So again, that's the best study that we have on this. It's like one of the few prospective papers. And the other paper is the Peterson et al. 2022. I've reviewed that one for PhysioTutors. So if you want to look at that, you can log on their apps. But basically, they had, I think it was 20.5 million patient hours, and across like, I think it was like 800,000 patients, and they looked at people's neck positions, and they found, is being bent more, or being upright more, or moving your neck faster, is that related to developing cervical disc hernias? And it wasn't. Yeah. And the way they did that, they used what's called a job matrix. So basically, you have jobs, you follow, like, I think it was about like, I think it's like 6 to 10 people a day that are doing a job, and you kind of take a baseline of like how people move during those jobs, like an average. You take a snapshot, like, oh, this is how people move throughout the day. Take an average of which position they spend the most time in, so you can get it like a picture. So they'll compare like an office worker to a factory worker to a garbage truck disposal person. And then you'll look at who gets cervical disc hernias. And they didn't, when you adjust for all the factors, there was a trend that like more neck flexion was protective. Again, a trend, so not statistically significant, but you can't say that flexion causes disc hernias. It doesn't. And then I think the only variables that remain meaningful after adjusting for all of those variables was the velocity at which you move your neck. So people that had more average velocity, like they move their neck more, I think it was in dynamic neck movements. Well, it didn't predict like cervical disc hernias. You have to read the whole paper, because if you just read the conclusion, it's misleading. But basically, again, when you adjust for all the factors, it seems like moving your neck is helpful. The other doesn't seem to matter in a statistically significant matter. So again, these are the two best papers. They show the opposite of what's recommended in terms of a good posture for what I guess PRI people would say, or any person that says focuses on posture. It's like, okay, it seems like slouching might be helpful, maybe a little bit. And we can probably definitely say that a large portion of the findings that we see in cross-sectional studies that are retrospective is probably like reverse correlation. This is just people that it feels better to be in that position when they're in big pain, rather than that position being the cause of pain. So yeah, basically the sit up straight dogma is probably dog shit. Yep. Anything?
No, I think we can jump to the next part of the discussion, which is like the more clinical side. If you want to use PRI, what you can actually do to make it feasible.
Yeah, I actually think that we went over all my points already.
Okay.
Yeah.
All right,
go
cool.
ahead.
So, PRI's main thesis is to utilize movements to create postural awareness, and I think that this idea in isolation isn't corrosive or bad. In fact, some data suggests that you can increase postural awareness to reduce pain. So one of those studies is Cram et al. 2018, so I'll pull that up real quick and share it. So it's this guy right here, postural awareness and its relation to pain. Validation of an innovative instrument measuring awareness of body posture in patients with chronic pain. So basically, what this study suggests is that higher positional awareness is moderately correlated to less pain in a sample of 512 chronic pain patients. So the program was mostly mindfulness and Qigong based. It did not seem to vilify specific postures. It just made people more aware of their sitting position. So Lexi mentioned that this is similar to like a difference between fascism and multiculturalism, where fascism is like this exclusionary thing where you want to keep certain type of people out of your country effectively. And multiculturalism welcomes all people. So this study isn't saying that any posture is bad. It's saying that no posture is specifically bad. Just be aware of all of your postures. And that seemed to have a correlation with your pain. So the better the positional awareness, the better people were able to modulate their pain. What we don't want to do, and this falls on that, or falls subsequently from that last point, what we don't want to do is choose to utilize PRI principles or exercises to propagate the idea of kinesiophobia, obviously, which some evidence suggests may actually worsen pain. So an Andrews et al. Study from 2012 suggests that the total avoidance of pain-inducing activities actually worsens pain. So I'll pull this one up real quick. This guy right here. So here we are, activity pacing, avoidance, endurance, and associations with patient functioning and chronic pain, a systematic review and meta-analysis. If we go down. Okay, I'll just read the conclusion. Although causation cannot be determined, results of the study suggest that both avoidance of activity and overactivity are associated with poorer patient outcomes. So this basically talks about two different types of copers when it talks to when it has to do with pain. So people who completely avoid pain versus people who would just kind of work through the pain and are overactive, both are associated with poorer patient outcomes. So that's a paper that illustrates that kinesiophobia and avoiding the pain in totality will probably worsen your symptoms. And then another paper that kind of shows a similar thing, it shows that kinesiophobia is associated with pain intensities, Vega et al. 2018. If you pull up this one.
Yeah. I'll pull up another B. Smith.
This guy right here. So it says kinesiophobia is associated with pain intensity, but not pain sensitivity, which is actually interesting. Before and after exercise, an explorative analysis. So if we go down, patients with a high degree of kinesiophobia demonstrated increased pain intensity compared with patients with a low degree of kinesiophobia. I want to get to this other point too, though, which is kind of interesting. Aerobic and isometric exercises increased pressure pain thresholds, but no significant group differences were found in pressure pain thresholds before and after exercise. So I actually thought that exercise would modify pressure pain thresholds, but in this study it doesn't look like it did. But the point remains that kinesiophobia actually modifies how intensely people seem to feel pain. So basically, if you want to do PRI, just don't do it in a way that's kinesiophobic. I would, if you really want to, you can include the exercises for PRI that are typically associated with PRI. One of them is like this 90-90 wall sit with a balloon for breathing. And although that looks ridiculous, it actually does help some people. So if you want to use stuff like that, I think it's totally fine to use stuff like that. Just don't do it with, a malicious or nocibic context that is pretty clearly indicated to make people's pain worse or that's the caveat there. One more thing that I wanted to show.
Could you explain? Yeah, we're going to talk about Warren Chat, but could you explain? Let's say you're using the balloon the way.
Yeah,
I'll do the way a PRI guy would say it, maybe.
Sure.
And then you could do it the way you would explain it, the way if you were to give it, for instance.
Mm-hmm.
Let's say I'm not a PRI certified guy, so I'll say like when we're doing this, we're helping your flared rib rotate better, which helps your scapular biomechanics, which will help your flexion. Like shoulder flexion go further, which probably reduces the impingement on your shoulder. So we want you to be able to breathe diaphragmatically, which is what this drill emphasizes. Okay, that's one. Again, I have no idea if that's how PRI does it. From what I read, it should be something like that.
Pretty similar, yeah.
Yeah, not the details, but the points. Okay, and then how would you explain it? You want to do that drill. That patients want to. Probably for you, I know you. Like the patient would want to do this, and you're like, sure, you can do that as a warm up, maybe. How would you explain it to him? He's like, teach me how to do it correctly or something. And why are we doing this?
Yeah, basically, I think with all PRI and things that I think all these models basically over medicalize nomenclature and use a very biomechanically reductionist view. So I kind of take all that out of the explanation. So I'd say, hey, if you want to do this 90-90 wall drill for intra-abdominal pressure, there's no problem with that. What we're going to try and do here is just be a little bit more mindful about your intra-abdominal pressure. And I want you just to feel the sensations of quote unquote stiffening your spine. I want you to feel what it feels like to increase that intra-abdominal pressure. And I just want you to be aware of the sensations that are going on during this exercise to maybe bring a little bit more awareness or mindfulness to the spots of your low back that are currently in pain. So I basically just use it as almost like this psychological cue of like, okay, there's the pain. I'm breathing now. Maybe I can attenuate some of that pain with different methods of breathing. If I pressurize my abdomen, maybe I can completely ameliorate that pain. And that's pretty cool. Like maybe I can use this as a tool, but I don't build up the exercise as more than that, especially not, biomechanically or I don't harp on the anatomy of it. And I think that's the fault of a lot of people.
Yeah. And if people are not familiar with mindfulness or don't know how to apply it, again, I don't know if it matters to do it this way, but that's when I used to do therapy. That's how I was taught it. It's just a super simple one. It's like a 5x5. So it's just you name 5 feelings like in your body. You name 5 smells, 5 things you're seeing, and then 5 things you're hearing, and then 5 things you're thinking. I think that's 5. I might be missing one. The point is you're in contact with what's going on around you and your body and your relationship to the space, which is kind of like the opposite of what we're put in this like crazy modern lifestyle where you're always on your phone, always like hyper aware. Not maybe hyper aware, but hyper stimulated. And it's just like, okay, what the hell is going on? I'm letting my thoughts run and like letting, basically being mindful. That's a super, you don't need like a PhD to be able to do that. Again, do you need to do it that way? Probably not. Does it better to do that? I don't fucking know. I'm not a psychologist, so do not cite me on this. It's one way you can do it. I found it helpful. But again, I'm not doing like, this isn't like the Nobullshitphysio protocol for mindfulness. Don't do that. Okay.
Yeah, I find clinically that if you just don't scare them with the anatomy and you give them the ability to just hone in on what that feels like in the moment, that tends to be enough.
Yeah.
But I just want to real quick go into this worm chat. So this is a guy that I've actually spoken to like quite a bit in the DMs about his how he actually lifts weights. So his squat looks crazy and his deadlifts look even crazier. So
kyphosis,
if you
right?
want, he has him, and we talked about kind of his family lineage. His dad, his grandfather, all of them have like really severe thoracic kyphosis. So when he does movements that involve lumbar kyphosis, his form looks even crazier because it's like his whole spine is kyphotic during the lift, which is insane. But if you wanted to use PRI and you wanted to see how, I think it's okay to use PRI and almost use that as kind of, as you mentioned beforehand, since you kind of know how I treat clinically, almost like a warm up to doing things that are a little bit more high performing or things that are a little bit more closely associated with strength and conditioning, like a barbell deadlift or a barbell back squat. If you wanted to use PRI as a way to create mindfulness, to transfer that mindfulness over in terms of your cueing for intra-abdominal pressure for back squats and things like deadlifts, I think that's totally okay. And that's how you should use it if you're working with an athlete specifically. But let's take a look at Worm Chad, because this guy is clearly not mindful of his posture. Tisk, tisk, just kidding. Check this guy out. He's super cool. He's a nice guy. All right, let's check out this man. I just got to pause there in the bottom position of this.
Yeah. Go ahead.
I mean, look at that.
Jesus.
That is what peak male performance looks like.
Yeah.
And when I had a discussion with him, and I sent him actually several of his own videos, and I was like, "You're telling me that you don't feel pain during any of these squats?" And he goes, "I feel fantastic when I squat." He goes, "I feel incredible. I have no pain ever." And he's like, "It's just my thoracic kyphosis that all the men in my family have that makes this look even worse." And then he actually sent me a picture of his dad, who has like, it was a profile view. And his dad did have a lot of thoracic kyphosis, but apparently no mid-back pain or low back pain or anything like that. This is just the way this guy's biomechanics works.
You might have fusion. So like he basically, it's like, I don't know. You know how the joke that your spine's not meant to move? If it were not meant to move, it would just be fused.
Right.
Maybe he has that, but just in the wrong, and I'm using quotation marks here, wrong position.
Sure. Yeah. Yes, I mean, this guy is like a living, breathing antithesis to the idea that everything has to be everything has to be symmetrical, or else you're going to feel pain. This guy is like clearly lifting, quote unquote, incorrectly, and has no pain whatsoever, and is thriving and is getting stronger. So pretty good.
Devil's advocate, maybe he's extremely stable because his whole spine is fused. It's just like a Miguel on crack kind of version. He's done so many bird dogs that his spine is fused stable. In the wrong position though. Right. That's super interesting. I love that guy. So again, just to reiterate the whole thing, the point was, even if we give them credit of that, we say, okay, your jaw, so your TMJ's posture changes to posture across the body. So what? Because it doesn't seem like we can agree on what's a good or bad posture, and it doesn't seem like there's a consistent causal correlation between posture and pain. So it's like, why would you spend your time with that? Of all the things you could do in a session with the client, especially since, again, as Eliud eloquently mentioned, kinesiophobia can be easily triggered with people. Like they'll be like, "Oh no, I don't have to do that." They're always going to be conscious of how they eat or move their mouth or whatever. which is probably not a good thing either, because that can potentially worsen the pain or be associated with persistent pain. And it seems like it's good to more like reframe that to be, have more like body awareness than body shame, if that makes sense, or positional shame.
Yeah, basically PRI, and this is something that I think any chiropractic student watching this podcast in particular will feel like probably triggered, and it'll probably resurface some of their PTSD from chiropractic school, which is heavily steeped in this anatomical possibilism, which is basically the unproven association that two anatomical structures are related to one another. So subluxation model and PRI are really similar in that way because they're really, really concerned with treating asymmetries and making the person as symmetrical as possible in an effort to ameliorate clinical symptoms. So PRI uses exercise to do that, and in contrast, chiropractic uses spinal manipulation to do that. But it's unlikely that either of these ideologies work by the way of changing anatomical structures, obviously. And in fact, studies like Carvalho et al. 2022 prove that chiropractors don't actually change the spine of pelvic postures, post manipulation. So this is actually a pretty cool paper just to pop up real quick, because this contradicts classic chiropractic claims that spinal manipulations actually change postures. So if we looked at this says 2022 study the effect of lumbar spinal manipulation on biomechanical factors and perceived transient pain during prolonged sitting, a laboratory controlled cross-sectional study. So if we just go down, there were no significant differences in spine or pelvic posture or perceived back pain following either the manipulation or control maneuvers. So either sham manipulation or true spinal manipulation. Significantly reduced muscle activity and increased shifts of the lumbar spine angle were identified in the block following manipulation compared to both baseline and control blocks. So conclusion is spinal manipulation does not appear to have an immediate impact on spine or pelvic posture in healthy adults, but does appear to reduce spine muscle activity and increase spine movements during sitting. So main thing here is that the adjustments don't have an immediate effect on the spine or the pelvis. So just like PRI probably doesn't actually truly change the anatomy of the spine or the anatomy of whatever structure they're trying to impose differences on, chiropractic doesn't do that either through spinal manipulation. So the two are very similar in the core thesis of their arguments, and they probably both don't work in the ways that they are supposing that they do. So despite this, patients may still obtain relief, obviously, from either PRI or chiropractic, and that's because the intervention can work for some people irrespective of the reasoning attached to the treatment. So PRI can help, quote unquote, improve posture and decrease pain because of the treatment effects of therapeutic exercise, and spinal manipulation may lead to temporary pain relief and postural improvements, quote unquote, due to the neuromodulatory effect of manual therapy. So that means if we want to borrow from either ideology, we should just separate the treatment from the school of thought and modernize the rationale. And you can do exercises from PRI or manipulations from chiropractic without the promise of fixing asymmetries or changing anatomy or improving posture or curing cancer. And you can still manage to do well by your patient.
Yeah. I'll add to that. For me, like we used to think that like when we did hip exercises because it was fixing knee valgum. When I started out my career, that's what I would tell. We got to fix that knee going in. And I saw these papers showing that, that didn't predict injuries. We'll talk about it in future papers, and then we've talked about it already. So I'll just use that example. The scapular dyskinesia papers. I use motor control exercise. I still use them a lot, but I just don't focus on the technique. I'm just like, okay, like feel what's going on in your shoulder and do it in a comfortable way. And it's low load movement or like a relative rest for more active people. And for sedentary people, it is a workout. It's just a gentle workout that's in a safe environment. And it works despite using different reasoning. So again, it's just don't get married to the narrative. And if you read data a lot, if you're actually interested in the science, I'd say people are like, oh, well, it changes all the time, so it's worthless to read data. Honestly, it doesn't that much. It's more the effects, the mechanisms that will change. But the effects are quite stable across time. So if you have a meta-analysis that shows effects based on good RCTs with decent sample sizes, it's unlikely to change. The rationale, very likely it'll change because humans are so complex. You've got all these overlapping mechanisms. It's hard to pinpoint which one. But pinpointing the effect, like the endpoint, is pain better, is disability better? That tends to stay more stable over time. So I'd say focus on that and then maybe do the rest as a hobby. Because it's interesting to know how it works. It's just, honestly, you don't really need that for the patient. You just need to give them an example. You don't need to tell them exactly how it works. Often I just say like, oh, it's the neurophysiological effect. And then maybe I'll explain it more simply to the patient, but I'll be like, it stimulates the zone, which seems to be helpful for pain. And, it kind of tells the body that, it's okay to move. I don't think I'm lying when I tell the ability. Is it that what's going on per se? Probably not. But again, it is an ethical way to explain it. That's not going to nocebo your patients. You don't have to pick that one. It's just one I use. And I use a bunch depending on the patient. And again, I just want to, because Eliud, we're not going to go into that. We'll probably do a podcast on subluxations alone. But I just want to share this. If people want the data, there's a lot of data on why the subluxation theory should be let go. I did a video on it with all the data, 3-minute 15. Physio explains vertebral subluxation. It's on my page. If you want to look at that, I explain also how even if we accept the premise that correcting the subluxation would fix the problem, manipulations are so, we know that from the McGill papers and other papers. If that were the case, manipulations would more often than not make the misalignment worse, because the margin of error is pretty big. So it's like 2 to 6 segments are hit every manipulation. So if it were the case, most cases you'd be making the misalignment worse. So you can't have your cake and eat it too. Either it's imprecise and you're making patients worse, or it's not how it works. I think you should choose the latter. It's not how it works, but it might be helpful for pain to do manipulations. But it's not by correcting physical misalignments per se. Yeah, so I think we've done like how we spin our treatments differently in a non-nocebic way. I think you did it for the manual therapy angle. I did it for the exercise angle. So I just want to conclude PRI's TMJ theories are a house of cards built on a series of unproven and often dubious juxtaposed hypotheses based mostly on low quality data, which goes against solid data that we have on other joints.
Yeah, so if you want to use PRI, that's totally fine by us, but you should choose a different, more modern, scientifically accurate, and likely less harmful narrative when providing said care.
Yeah, on our end, we will continue not providing PRI because we think it is a little bit silly, patient intensive, and requires constant focus without currently posting any studies showing superiority to other cheaper and simpler approaches. And probably more expensive than just a more laid back approach of hey, do this, you'll probably feel better regardless of biomechanics. Yeah.
Cool. All right. Well, I think that's it.
Yeah, this will be on all platforms. So when this is up, if you can give us a good review, if you liked it, if you don't like it, just, I don't know. Just don't say anything, please. We need this to go well.
Yeah, give us a good review on Spotify. That'd be helpful.
But it'll be on all platforms. And it'll be edited down also. This is the long version where people just want this stuff right away, but we'll shave it down, and we'll also do reels to make it more streamlined online for audio listeners. You can find me on all platforms at Nobullshitphysio, YouTube, Instagram, and Twitter mostly.
Yep, and I'm on all platforms as well at The Rehab Cairo.
All right, this was the Fact Check podcast. You can find us probably next month, and we'll probably have Diego. I don't know if I can say his name. Yeah, Diego, the skeptical physio guy, super interesting guy from Spain. So it'll be an international podcast. Well, I mean, it already is because I'm Canadian and Eliud's in Chicago area. As far as I know, yeah, Illinois, I guess. But yeah, so I guess we'll see you next month, and hopefully this will be good. All right, have a good one.
Sweet. Peace.